Hello guys, warm welcome to all of you. Now the INI-CET May is done and dusted. Here we are to discuss the physiology questions asked in that exam. As I have seen the questions, physiology, particularly as far as physiology is concerned, the questions came from the time-tested repeat areas except one or two new questions. Now, as I already told you in the last discussion itself, you already know the fact or a concept. They are going to convert that into either a clinical scenario or a graph or an image-based question. That's all. You know already. To justify the same statement, I'm showing you the first question where the concept or the fact was discussed in the videos before, but they converted that into picture-based MCQ. Now look into the question, guys. What is the question? The type of hypoxia based on the graph is, and this is the graph. Any idea? Just think for a moment. What you answered for this question actually? If you answered it is anemic hypoxia, you are correct. Why, sir? What is the concept? Let's analyze this graph to reinforce the fact or the concept of what we know already. Remember, guys, this graph is about the oxygen dissociation curve, yes, sir. The shape of this graph you can appreciate is S-shaped. We call this as sigmoid. This graph has got x-axis and y-axis. What is x-axis, sir? Partial pressure of oxygen. Yes, true. What is y-axis, sir? Y-axis is the percentage saturation between hemoglobin and oxygen. We call this percentage saturation as the oxygen content. Now look very carefully, particularly anemic hypoxia. What is actually happening? There is reduction or fall in hemoglobin, qualitative and quantitative reduction in hemoglobin. That is anemic hypoxia, right? There is fall in hemoglobin. Most importantly, in this hypoxia, PO2 or the dissolved form of oxygen is normal. Only the oxygen content or the form that is combined with the hemoglobin will be reduced, but the PO2, the dissolved form, is always normal in anemic hypoxia. Now look into this important graph. This dotted line is normal hemoglobin 15. You are seeing the arterial oxygen content around 19, normal. The venous blood oxygen content around 40. Simple. Now look into this straight line, that is hemoglobin 7.5. Fall in hemoglobin, anemia, anemic hypoxia. The arterial oxygen content is reduced to around 9. Yes, we are seeing. The venous oxygen content reduced to 4. From 19 and 14, it is reduced to 9 and 4. More than half percentage reduction, more than 50% reduction. We call this as anemic hypoxia. Where the PO2 in this line, the graph looks normal. From top to down, if you clearly see, the oxygen content is reduced. So anemic hypoxia, there is decrease in oxygen content, that is the form that is bound with hemoglobin is reduced. PO2 is normal. So the answer is very simple. In this graph, we are clearly seeing there is fall in oxygen content. There is fall in saturation. That is why the answer we are going to choose for this is anemic hypoxia. The concept we know, they asked that in the form of a graph, you should be able to apply that. Simple. Now let's move into the next question, guys. Assertion and reason. Resting membrane potential depends on proteins and phosphate ions. True. Reason. Diffusion potential can be calculated using Nernst equation. True. Both are true. But is the reason explanation for the assertion? Definitely no. Both are true statements. Reason is not the explanation for that assertion. Now look very carefully, guys. Why we chose this answer? Consider this cell. Any cell for that matter. This cell is at rest. What is the basic concept we all know? Positive charges are always getting balanced by negative charges. This positive charge consider as a potassium ion. The negative charges inside the cell can be either proteins or phosphates. Now, even at rest, there is diffusion of potassium ions. Potassium ions are diffusing out. That means the positive charge is moving out. The negativity is accumulating inside. The negativity is accumulating inside. So the basic cause for the resting membrane potential is diffusion of which ion? Potassium ions. What is accumulating inside? Proteins are accumulating inside. Phosphate accumulating inside. They are anions. They give a negative charge. So this inside negativity is called as resting membrane potential. Simple. Potassium positive charge is moving outside. So the inside negativity is not balanced. They are getting accumulated. The inside negativity is because of proteins or phosphate. If this is the explanation, we should choose both are correct. Reason is the explanation. But what they are giving, they just give a broad statement. Diffusion potential can be calculated using Nernst equation. Diffusion potential or Nernst potential, all mean known the same, or equilibrium potential, all mean known the same. This is also true statement, but reason is not the explanation for the assertion. What is the explanation for the assertion? RMP depends on proteins and phosphate. Reason. This is because of diffusion of positive charge potassium ions. If this is the reason, this can be the explanation. But the reason is something different. They gave a true statement, but the reason is not the assertion, is not the explanation for the assertion. Simple. RMP depends on proteins and phosphate ions. True. Diffusion potential can be calculated using Nernst equation. True. Both are true, but the reason is not the explanation for the assertion. Simple. The answer is B. Next question. Increase in BP at the beginning of Valsalva is due to, any guess, Valsalva maneuver? The answer for the question is very simple. It is the increase in intrathoracic pressure adds to aortic pressure. Now, this graph analysis is very important. Definitely a question for the future. I'm telling you guys. This explanation, please listen deeply. What is this Valsalva maneuver? Very, very, very simple, sir. Look very carefully. Valsalva is none other but forced expiration against closed glottis. Forced expiration against closed glottis is our Valsalva maneuver. Now look very carefully. This Valsalva maneuver is mainly useful to assess the components of baroreflex. Now look very carefully, guys. There is an important law that is called as Mary's law. What it states that blood pressure and heart rate are always inversely related. If blood pressure rises, there will be reflex fall in heart rate. If blood pressure rises, there will be reflex fall in heart rate. They are inversely related. What is this law? Mary's law. Now the baseline is set to analyze this graph. That's all I was trying so far. Valsalva maneuver is forced expiration against closed glottis. It is useful to assess the components of baroreflex. Blood pressure and heart rate are inversely related. Now look very carefully. There are 4 important phases. Phase 1, phase 2, phase 3, phase 4. Now look into phase 1. What is this phase 1, sir? It is none other but the onset of strain. Onset or beginning of this Valsalva maneuver. Because of this, remember very, very, very carefully, there is increase in intrathoracic pressure. Onset of strain, there is compression of chest wall. There is increase in intrathoracic pressure. This is definitely going to compress thoracic aorta. Simple. Phase 1 is the onset. There is compression of chest wall, forced expiration, compression of chest wall. There is increase in intrathoracic pressure. There is compression of thoracic aorta. This compression is a form of vasoconstriction. it is going to increase blood pressure. Phase 1, there is increase in blood pressure. It is the mean aortic pressure. It is adding to the aortic pressure. We are clearly seeing there is increase in blood pressure. So this graph is for aortic pressure or blood pressure. There is increase in blood pressure. Look into Mary's law. If blood pressure rises, heart rate will fall. So what is happening in phase 1? Blood pressure is rising. There is a reflex fall in heart rate. Now look very carefully. What is phase 2, sir? Because of compression, because of increase in intrathoracic pressure, there is going to be decrease in venous return, obviously. When there is decrease in venous return, there will be decrease in cardiac output. When there is decrease in cardiac output, there will be decrease in blood pressure. Simple logic, we are seeing there is a fall in blood pressure. According to Mary's law, when blood pressure falls, heart rate will definitely rise in phase 2. In phase 2, decrease in venous return, decrease in cardiac output, fall in BP. Automatically, there is reflex increase in heart rate. What about phase 3, sir? Phase 3 is the release. We ask the subject to relax. Done. You did with the Valsalva maneuver. Now relax or release. That's all. This phase 1 is the onset. This phase 2 is maintaining the stress doing the maneuver. This phase 3 is release. Exactly in phase 3. Remember carefully, guys. In phase 1, there is increase in intrathoracic pressure. In phase 3, there is decrease in intrathoracic pressure. Automatically, there is decrease in blood pressure. We are clearly seeing in phase 3, there is decrease in blood pressure. According to Mary's law, heart rate will rise. What is phase 3? It is the release. Release means there is fall in intrathoracic pressure suddenly, there is fall in BP. What is phase 4, sir? This is called as overshoot. There is suddenly, after this maneuver, going to be tremendous increase in venous return, tremendous increase in cardiac output, there will be increase in blood pressure. When blood pressure rises, definitely heart rate will fall. That's all. Valsalva maneuver, forced expiration against closed glottis. What is phase 1, sir? Onset. Increase in intrathoracic pressure, compression of thoracic aorta, rise in BP. Rise in BP means fall in heart rate. What is phase 2? Maintenance of stress, that is doing the maneuver. During this maneuver, there is fall in venous return, fall in cardiac output, fall in BP. Automatically rise in heart rate. What is phase 3? Releasing that stress. We ask the subject to stop doing Valsalva maneuver. There will be decrease in intrathoracic pressure, decrease in BP. And finally, once everything is done, automatically this phase 4, you will see in all individuals overshoot. At the end of this maneuver, there will be tremendous increase in venous return, increase in cardiac output, and increase in blood pressure. Increase in BP means decrease in heart rate. So this is useful to assess the components of baroreflex. Now let's go back into the question. Increase in blood pressure at the beginning of Valsalva. I clearly discussed this point. There will be increase in intrathoracic pressure. This adds to the thoracic aortic pressure. So increase in intrathoracic pressure adding to aortic pressure. The answer is definitely option B. Now next question. Pressure measured at upper airway becomes 0 when measured at which volume or capacity? As I told you, I think this question is asked around 7th or 8th time now. You should never make a mistake in this question. It is the ditto repeat MCQ. The answer for the question, I am also discussing the same question, same answer in all the recall sessions, functional residual capacity. I think you will be sure, you will be very thorough with the explanation part now. The answer is F or C. Now look very carefully, guys. This graph is about the compliance. We have 3 important compliance graphs shown here. The first one is the compliance of chest wall. The second one is the compliance of lung. The third one is the total compliance, which is the compliance of lung plus compliance of chest wall. Three important compliance graphs shown here, which is the compliance of chest wall, compliance of lung, and the total compliance. We are clearly seeing in lung there are always two opposing forces. The first one is the chest wall. It always tries to expand out. The second one is the lung. It always tries to collapse inside. Chest wall have a normal tendency to expand outside. Lung always have a tendency to collapse inside. There are two opposing forces, and both these forces, chest wall trying to move out, look into the arrow mark. Lung is trying to collapse inside. Both these opposing forces come to balance at one point. That point is FRC. You also call this point as, remember guys, equilibrium point. At equilibrium point in lung, you get a volume of around 2.5 liters. That is our functional residual capacity. It is also called as relaxation volume or equilibrium volume. One more important question. Look very carefully. If you allow the lung to undergo complete collapse, the lung is completely collapsed. For example, the clinical state, pneumothorax. Even the lung undergoing complete collapse, it still encloses some volume of air that is called as minimal volume. Even though the lung undergoes complete collapse, it is totally collapsed. Even that collapsed lung still encloses some volume of air, and that volume is called minimal volume. Two important questions asked before here. Both these opposing forces come to equilibrium at FRC. Second question, completely collapsed lung still encloses some volume of air, that is minimal volume. Simple. Now, let's look into the next question. Which of the following hormone acts via this pathway? What is this pathway, sir? JAK, Janus kinase, STAT. A very important concept, guys. Look very carefully. The answer for this question is leptin. Most important first point. What is JAK stands for, sir? We all know Janus kinase. What does STAT stands for, sir? They are signal transducers and activators of transcription. Genetic machinery, transcription. Remember, Janus kinase, signal transducer and activators of transcription. Most importantly, they are going to be used by cytokines. That means something concerned with immunity. The next important hormone, growth hormone. The third is prolactin. The fourth is erythropoietin, particularly the isoform is Janus kinase 2. And finally, a new information for you, the hormone leptin, concerned with energy homeostasis. It is regulating appetite or satiety. Leptin, energy homeostasis, particularly uses this pathway, JAK-STAT pathway, exclusively STAT3 and STAT5. Very important. Janus kinase, signal transducer and activators of transcription, used by cytokines, growth hormone, prolactin, erythropoietin, which is using JAK2, and leptin, which is going to use STAT3 and STAT5. Most important concept. Look very carefully. We have something called as SOCS. Another very familiar MCQ you can expect. They are considered to be the natural inhibitors of JAK-STAT pathway. What does SOCS stands for? Remember, suppressors. Suppression of C stands for cytokine signaling. Very important MCQ concept. We have certain group of molecules called as SOCs, which stands for suppressors of cytokine signaling. This group of substances, SOCs, they are going to form complex with this JAK-STAT pathway elements. They are going to form a complex. And this complex induces the binding of ubiquitin. And they will be taken to a very important graveyard for their destruction. What are they? They are our proteasomes. Eventually, they will undergo destruction. Very important point for you. It can be asked because something called as suppressor of cytokine signaling, they are the natural inhibitors of JAK-STAT. Knowing this is a fact, fact is no longer needed. You have to remember the concept. What is the concept? When SOX combines with JAK-STAT pathway elements, this complex induces the binding of ubiquitin. They will be taken to proteasomes, eventually destroyed. When they are destroyed, means no further signaling. Now, clinical significance, particularly erythropoietin, JAK2. There is an inhibitor. What is this inhibitor drug? Any idea? This inhibitor drug is ruxolitinib. This is inhibitor of Janus kinase 2, particularly needed for treatment of polycythemia vera, where there is overactivity of erythropoietin. Clinical importance, remember this point. Erythropoietin, JAK2 inhibitor, ruxolitinib, treatment of polycythemia vera. JAK-STAT pathway, one important hormone that is going to use this is leptin. So the answer we are choosing option D. Remember, we have discussed a whole lot of points concerned with this JAK-STAT pathway. Remember ruxolitinib, all our favorite MCQs. Next. Given below are neuroanatomical structures. Arrange the following from receptor to cerebral cortex. The answer is very simple. Auditory pathway, very simple concept. To understand the components, you need to remember something called as this mnemonic. What is this mnemonic, sir? E. coli, MA. What does E here stands for? E is our eighth nerve. Particularly C stands for the cochlear division. These cell bodies of the cochlear division is located in the spiral ganglion. This spiral ganglion is going to innervate our hair cells. Those neurons that are going to innervate our hair cells, their cell bodies are found in the spiral ganglion. Then the cochlear division, O stands for superior olivary nucleus, where the direction. If any sound is coming from this side, I can automatically turn my head. Coming from this side, I can turn my head. So sound localization. From which direction the sound is coming, it is very important. This superior olivary nucleus has got a role in direction. L stands for lateral lemniscus. I stands for, remember, inferior colliculus. It is also one more area for direction. Superior olivary nucleus, inferior colliculus. Both are important for direction processing. M is our medial geniculate body in thalamus. A is the auditory cortex, which is particularly located in the superior temporal gyrus, which can be also called as Hazel's gyrus. So it is the spiral ganglion, eighth nerve, cochlear nuclei, superior olivary nucleus, lateral lemniscus, inferior colliculus, medial geniculate bodies, and auditory cortex, which is the superior temporal gyrus. Now let's go back. Given below are neuroanatomical structures, arrange the following from receptor to cerebral cortex. We can arrange in what order? Spiral ganglion, cochlear nucleus, then olivary nucleus, fourth inferior colliculus, and the fifth medial geniculate body. So it is 1, 2, 4, 3, 5. So the order is 1, 2, 4, 3, 5. Exactly. With the help of this mnemonic, you can easily understand. Next, Cells prolific in smooth endoplasmic reticulum secrete. Very, very important. We discussed this concept in our videos. A very beautiful concept. The answer is steroid hormones. Simple logic, guys. Endoplasmic reticulum, two important types. We have rough endoplasmic reticulum and smooth endoplasmic reticulum. Rough endoplasmic reticulum is totally concerned with protein, not only synthesis and also quality control. What is the meaning of this? Following protein synthesis, if the proteins are not properly folded, they will be destroyed with the help of something called as endoplasmic reticulum assisted degradation. Rough endoplasmic reticulum exclusively concerned with the protein. We have protein synthesis, we have protein folding. If not properly folded, destroy there itself. Quality control. That quality control checking point is rough endoplasmic reticulum for proteins. Now the major discussion is smooth endoplasmic reticulum. Remember the mnemonic yes. Exclusively yes stands first and foremost is storage of calcium, particularly in the smooth endoplasmic reticulum of skeletal muscle. Remember, it is this skeletal muscle. Smooth endoplasmic reticulum, calcium storage in skeletal muscle. Next, most important, remember, steroid hormone synthesis exclusively in the adrenal cortex. An important location. Steroid hormone synthesis, adrenal cortical hormone, steroid hormone, smooth endoplasmic reticulum. And most importantly, remember, drug detoxification with the help of cytochrome P450 group of enzymes, mainly in the liver. Liver cells have abundant smooth endoplasmic reticulum, large amount of smooth endoplasmic reticulum for drug detoxification, pharmacology, with the help of cytochrome P450. So, storage of calcium, steroid hormone synthesis, drug detoxification are the functions of smooth endoplasmic reticulum. Let's go back here. Cells prolific in smooth endoplasmic reticulum secrete steroid hormones. Remember adrenal cortex, steroid hormones. It has got plenty of smooth endoplasmic reticulum in its cells. Simple. For the next question. Arrange the following bands in sarcomere in its sequence from periphery to center. Another most high yield repeat area, sarcomere. This alphabets, everything we have discussed. Now let's look into this sarcomere. In this sarcomere, what defines a sarcomere? We all know it is the Z line. The area between two Z lines is one sarcomere. We have thin filaments, that is our actin. Then we have a thick filament, that is our myosin. This actin you classically see in the I band. This myosin you classically see in the A band. We all know actin and myosin overlap. Their overlap is the most important force that is needed for muscle contraction. Thin filaments actin I band, thick filaments myosin A band. Even though actin and myosin overlap, there is never a complete overlap. You can clearly see there is always a region where there is no overlap between actin and myosin. They are not overlapping. Here they are overlapping, here they are not. So this looks like an alphabet H. We call this as H band. Exactly in the middle of myosin, we have a line, and that line is M line. M stands for middle, M stands for myosin. So remember, periphery, Z, center, M. Now let's go back to the question. Arrange the following bands from periphery. So Z, next is A, next is the H zone, next is the middle M line. So it is in that order, Z, A, H, M. Now look into the question. Yes, we have Z, we have A, we have M, and this is our H. So Z, A, H, Did we choose correctly? Yes. ZAHM, from periphery to center. So these are the lines. We now know very clearly the area between two Z lines is one sarcomere. Actin is the I band. Myosin is the A band. The non-overlapping part of myosin is the H band. The middle line is the M line. So ZAHM. Simple. Next question. Another exact ditto repeat. True about skeletal muscle is R. Extracellular calcium is not important for contraction. Extracellular calcium is important for contraction. This is false. Why, sir? Particularly fall in extracellular calcium. This can lead to very frequent opening of sodium channels, increased number of depolarization, there is increase in contraction. We call this contraction as tetany. Extracellular calcium is important for contraction. It is not important means false. Why? What is the explanation? Fall in extracellular calcium, there is frequent opening of sodium channels, frequent depolarization, sustained contraction, tetany. So extracellular calcium is not important for contraction is false. Calcium is mainly released from the mitochondria? No, false. Calcium is exclusively released from the sarcoplasmic reticulum. True. Voltage-gated calcium channels on sarcolemma has no role in EC coupling. This voltage-gated calcium channels, for example, dihydropyridine receptor and ryanodine receptor, both are exclusively important. They have a role in excitation contraction coupling. This is also false. They are saying no role. It is false. They have a role. So A is false, B is false, D is false. Only option C is true. Calcium is mainly released from the sarcoplasmic reticulum. So option C is true. Remaining ones are false. Now, the next question. Our body was built to identify toxic substance by the recognition of bitter taste. This bitter taste is due to which of the following component? The answer is very, very simple, guys. It is the alkaloid. How to remember this? There are 5 important taste senses. The first one, let's consider salt, is because of ionic salts. For example, sodium, which is going to be detected by epithelial sodium channels. Second, remember, sour taste, which is because of the acid H+. This can also be detected using epithelial sodium channels. The third one is the sweet, because of sugars, aldehydes. Sweet. Fourth is the bitter taste, mainly due to alkaloids. For example, drugs. Remember, quinine, strychnine, they are toxic. Strychnine is particularly toxic. Its chemical component is alkaloid that gives bitter taste. And finally, the most recently discovered umami taste because of L-glutamate, which is detected by mGluR4 receptor. There are 5 important tastes. All are MCQs. Salt is because of ionic salts like sodium. Sour taste is because of acid H+. Sweet is because of sugar aldehydes. Bitter taste, alkaloids. Majority of the drugs have bitter taste because they are alkaloids. For example, quinine, strychnine. Umami taste, the most recently discovered, the highly addictive among the all is the umami taste because of L-glutamate, which is detected using metabotrophic glutamate receptor. So the answer for the question is very simple. Toxic substance, bitter taste. This is due to, remember, alkaloids. Now, the next question. Which of the following is responsible for fetal heart acceleration? Remember, guys, the most important question, physiology and obs gynae, it is carotid baroreceptors. The concept is very, very, very simple. in the fetus, the most important state, hypoxia. This hypoxia can activate peripheral chemoreceptor. Where are those peripheral chemoreceptors? Carotid body and aortic bodies. Most importantly, whenever they are activated exclusively during hypoxia, there is tremendous sympathetic stimulation. Sympathetic stimulation means norepinephrine. This norepinephrine can increase heart rate. It is going to cause vasoconstriction. There is increase in blood pressure. There is increase in heart rate. There is increase in blood pressure. Fetus, whenever it undergoes hypoxia, peripheral chemoreceptors are stimulated, carotid body stimulation, aortic body stimulation, but the most important is always carotid body for this response. There is tremendous activation of sympathetic stimulation, which is also called as the cardio-acceleratory center in medulla. Cardio-acceleratory center in medulla, tremendous sympathetic stimulation, norepinephrine comes, there is increase in heart rate. This is what we call the one asked in the question, fetal heart rate acceleration in response to fetal hypoxia. There is also vasoconstriction, which is alpha receptor mediated. There is increase in blood pressure. Very important. Now look very carefully. Which of the following is responsible for fetal heart rate acceleration? Carotid receptors, be it baroreceptors or chemoreceptors, they can be stimulated. Both can be stimulated. Eventually, there is tremendous activation of sympathetic nervous system. There is increase in heart rate. There is increase in blood pressure. Both can be stimulated, chemoreceptors, baroreceptors, in response to hypoxia. Both can be stimulated. And the common response you see is fetal heart rate acceleration. There is increase in blood pressure. So the answer is, even though carotid and aortic are there, you should always give preference to the most important one, carotid receptors. Both can actually do this response, be it baroreceptors or chemoreceptors. Both can be activated in response to hypoxia, and the response is tremendous sympathetic nervous system stimulation. The answer is carotid baroreceptors. Next question. Which of the following statement is false about male sexual development? Dihydrotestosterone leads to development of secondary sexual characters and external genitalia. Dihydrotestosterone for external genitalia, testosterone for internal genitalia. So this is a true statement. Wolffian duct develops into epididymis and vas deferens. True statement. Mullerian inhibitory substance inhibits Mullerian drug. True statement. At 8th week, fetus is bipotential. It is false. Up to 7th week, we call this as indifferent gonad, also called as bipotential. It can become either male or female. That is the meaning of two potentials. Can become either male or female till 7th week, not 8th week. So it is the false statement. Which of the following is false? The answer is definitely option D. Yes, D is the answer. Next question. Which of the following are incorrectly paired? Gastrin, G cells, antrum. Secretin, S cells, duodenum. Cholecystokinin, I cells, duodenum and jejunum. Motilin, M cells, duodenum and jejunum. All looks correct. Any idea? This is the most brilliant question set in physiology, I must say. A minute difference. Remember, it is MO versus M. It is the Mo cells that produces motilin, particularly in the upper small intestine. This M stands for, remember guys, microfold cells. Where will we see them? You see them in Peyer's patches, particularly in the ileum, mainly responsible for immune functions. So that is the difference. It should be MO cells for motilin in the upper small intestine. This M cells does not produce motilin. This M cells are immune cells having immune function, antigen presentation. They are found in the Peyer's patches, particularly in the ileum. They are called as microfold cells. So it is not M cells for motilin, it should be MO cells. So which is incorrectly paired? Definitely option D. It is not M cells, it is MO cells. Very brilliant question. Next question. Windkessel effect is shown by all except. What is this Windkessel effect, sir? The answer is radial artery. Why? This aorta has got a very high content of elastin. It is the one responsible for elasticity. What is this elasticity, sir? Which means in response to stretch, there is always elastic recoil. That means it is going to function like a spring. That's all. You stretch it, release the stretch, there is always elastic recoil. In German, this stretch-induced elastic recoil is called as Windkessel effect. In German, the stretch-induced elastic recoil is called as Windkessel effect. For this Windkessel effect, you need a large diameter arteries. You can see this in aorta. You can see this in carotid artery. And what is the third option? You can also see this in renal artery. True, found, true, found, true, found. Radial artery is a very small caliber vessel when compared to this above 3. They have large diameter, they have more amount of elastin, they can show this Windkessel effect. But radial artery compared to the above 3, it is having a very less diameter. You cannot expect a Windkessel effect in your radial artery. It can be found in carotid, it can be found in renal, it can be found in aorta, but not in radial artery. So as I told you guys, these are the questions. Around 14 to 15 questions came from physiology. All are very high yield ones from the very well-known repeat areas. But always remember, make up your mind, guys. Be ready. Be open-minded. This is what I'm again and again stressing. You know it already in the form of a fact or a concept. They will simply convert that into a clinical scenario or a graph or an image. Make yourself ready for that. Any question, any test you are attempting, always look for this feature, whether they are converting the fact or concept into a image or a scenario or a simple graph. So in physiology, these are the questions. I hope you guys did well. Many questions came from our videos. I wish you all the very best, guys. Good luck and best wishes. Thank you.